Bismillah ar-Rahman ar-Rahim. Greetings from Amman, and it gives me great pleasure to be with you during your annual meeting. And I would like to extend my deep gratitude to Professor Surur and the organizing committee for inviting me to participate. My presentation today is about ART and bariatric surgery. Obesity is very much in the news, and for good reasons too. We know the incidence is increasing dramatically and has more than tripled over the last 4 decades. In whichever country you look in the world, the line is going up. Obesity is increasing as we get more affluent. And we don't dislike obesity just because the shape is not to our liking. The main ill effect is health. Obesity is actually defined as excess body fat that's detrimental to health. And if you look at health risks of increased weight, it basically goes like this. Anything that can kill you or make you ill will become more common with obesity. You name it, they've got it. High blood pressure, type 2 diabetes, coronary heart disease, stroke, cerebrovascular accident, breast cancer, and bowel cancer are just some of the many things that obesity will make worse in you. And we measure it by relating the weight to the height. The body mass index, as we know, is the weight in kilograms divided by the height squared in meters. And between 20 and 25, the BMI is normal. Over 25, you're overweight. 30 to 35, obese. 35 to 40, extremely obese. And over 40, it's morbid obesity. Its incidence is increasing worldwide, and particularly increasing over the past few years in developing countries, more in women and more in the reproductive age group. What does that mean? It means that next time you go into your fertility clinic, you would see more and more obese patients compared with what you have seen in the past. And unfortunately, this trend is set to increase. So what we need to do in the next 10 or 15 minutes or so is to understand how common obesity is, what effect it has in pregnancy and in assisted reproductive technologies, how obesity is managed, and because bariatric surgery is now a fundamental part of the management of obesity for reasons that we shall discuss, we need to understand the relationship between bariatric surgery and obesity and ART. Obesity is very common, and if we take the UK as one example, we'll find that more than 1 in 4 women have BMI more than 30, that's obese, not just overweight. About 3/4 of them are in the reproductive age group, and that led to 1/4 of them to be suffering from infertility. And if we look at admission to hospitals with obesity or admission for bariatric surgery, definitely in the UK, female outnumber their male counterparts by a ratio of 3:1. Moving into more familiar terrain, in my own country, Jordan, a study performed in the north of the country in 2008 showed that more than half of the women studied were obese, BMI more than 30. Again, they are mainly in the childbearing age group, and females outnumber males. Obesity not only is detrimental to health in general, but in particularly in pregnancy. This excess adipose tissue will predispose the pregnant women to many complications we would like to avoid. Gestational diabetes mellitus, preeclampsia, and other hypertensive disorders of pregnancy, macrosomia, induced labor, obstructed labor, cesarean section, thromboembolic manifestation, and all sorts of perioperative morbidity and mortality will be intensified by obesity. If we move to more familiar terrains such as ART, we will find many studies, and this is one study that was published in Human Reproduction Update in 2007 by Bhattacharya's group from Aberdeen. Meta-analysis and systematic review of the effect of overweight and obesity on ART showed that there is definitely lower pregnancy rate in obese patients. There is more need for higher doses of gonadotropins and lower response rate, and there is also a higher miscarriage rate if the woman becomes pregnant. Now, the cause of all these adverse factors is not known. Some people suggest that it might be a problem with oocyte or embryo quality. Other studies have disagreed. Some studies have suggested that there may be an endometrial defect because they showed in those studies that oocyte recipients will have variable success rate related to their weight, but different studies have disputed those findings. Therefore, we know that obesity will adversely affect your ART outcome. We just don't know why. Now, the key to managing obesity is weight loss, and the aim is around 5 to 10% weight loss. And primarily, this is done through lifestyle changes and physical activity, but as all of us know, this is much easier said than done. There is insufficient evidence to recommend one specific diet over another or a precise physical activity program over the next. And we know that it sometimes works, but most of the time it doesn't work. When that doesn't work, we move to pharmacological agents such as lipase inhibitors, and these have to be given by injections, either daily injections or weekly subcutaneous depot injections, and studies have shown that they are successful in a good number of patients in achieving at least 5% weight loss, but taking injections for life is probably something most people would like to avoid. And if that doesn't work, one option is to move to bariatric surgery. Bariatric surgery is indicated in patients who are morbidly obese, that is BMI more than 40, or in those who are extremely obese, 35 to 40, but with other comorbidities such as high blood pressure or diabetes. There are two types of bariatric surgery, either restrictive or malabsorptive. The restrictive type, the capacity of the stomach is restricted surgically in order to reduce the calorie intake and absorption, and the malabsorptive type is when we bypass part of the gastrointestinal tract to reduce the absorption of food. In young women who would want to get pregnant, we use laparoscopic adjustable gastric banding, LAGB, because the tightness of the band can be adjusted to accommodate for the increasing demands of pregnancy. And studies have shown that in those challenging cases, that's extreme obesity with comorbidity or morbid obesity, bariatric surgery is successful in the majority of patients, of leading up to 15 to 25% of weight loss that is sustained. And we have to remember that many people can lose weight with many management options, but it is sustaining that weight loss that is very important. Now, when we're speaking about bariatric surgery and ART, we have to differentiate either we are speaking about the male patient or the female patient, because hopefully, as I will illustrate, there are different ways of dealing with them on many aspects. Starting first with our female patients, we know that bariatric surgery is effective in making them lose weight and in sustaining that weight loss, and so it achieves the main aspects of the surgery, which improvement in the long-term metabolic health outcomes. We have to remember that this is our main goal. Also, it leads to normalization of menstrual irregularities and to restoration of luteal function in the majority of these women. And the hormones that usually increase in obesity, such as estradiol, testosterone, and dehydroepiandrosterone sulfate, will drop in their serum levels after bariatric surgery. And therefore, if extreme obesity was the only thing in the woman, or in the couple, I should say, preventing pregnancy, almost 54% of these couples will achieve spontaneous pregnancy within 6 to 12 months following the surgery. And we have to emphasize here that this is related primarily to weight loss and not to the procedure performed. There are no better or worse procedures. There are procedures that will lead to sustained weight loss, and it is sustaining this weight loss that will lead to all these improvements. Now, the first question is this: if a patient who is coming for IVF is either extremely or morbidly obese, ask us, Should she go for bariatric surgery before IVF, or should she postpone it till after IVF? What should we tell her? Do we have any evidence that bariatric surgery and the associated sustained weight loss will improve her chances of pregnancy? And the answer is yes, we do have evidence. Understandably, there are no randomized controlled trials with that, but this year in Human Reproduction, a study was published looking at the IVF outcomes in patients with a history of bariatric surgery. It was a multi-center retrospective cohort study. And what they did was this. They compared three groups. The first group was 83 women who were extremely or morbidly obese and have had bariatric surgery, and their weight dropped down just to the obese range, BMI of 28. They compared them to another group, 166 women of similar BMI, that is similar to the first group after they've had their surgery, but they didn't have any weight reduction surgery. And they compared them to a third group, another 83 women who were severely obese, BMI, mean BMI was 37, but they didn't have any operation. And indeed, there was an increase, almost a doubling of the live birth rate per transfer in the first and second group compared with the third group. So we know definitely from this evidence that we have that bariatric surgery before IVF will lead to a almost doubling of the pregnancy rate in these women. The second situation that may arise is when a woman who has had bariatric surgery presents to the clinic asking when should she get pregnant. And the advice here is very clear. She should wait for at least a year to a year and a half after the surgery, because inevitably, initially, there will be nutritional deprivation because of the reduced calorie intake and the reduced food absorption, and this has been shown in many observational studies to increase the risk of fetal growth restriction. So waiting is very important. Okay, let's assume she has waited this time and now she presents for her IVF cycle. We should be aware that a number of studies have reported a drop in AMH after bariatric surgery. This may be because of the passage of time or maybe because of the effect of surgery itself. Therefore, even if the AMH has been checked before, it is important to check it again and adjust the dose of stimulation medication accordingly. Another issue to do with medication is we know that after bariatric surgery there is excessive weight loss, which is actually the object of the exercise there, and there will be followed by skin redundancies. This skin redundancy will make the effective absorption of subcutaneous medication much less than intramuscular route. And there have been reports of empty follicle syndrome after the HCG injection was given subcutaneously in these women. We do not have a cause and effect proof, but definitely women who have skin redundancies after bariatric surgery, when they come for IVF, they should be advised to take all their medication intramuscularly. Moving on to the male patient after bariatric surgery, we should emphasize here that because of the significant and the sustained weight loss, there is improvement in the long-term metabolic health outcome. So all men coming to us and they have extreme or morbid obesity, if they ask our opinion about bariatric surgery, we should definitely recommend it to them. Mainly because of health improvement, but also because there has been evidence that there is normalization of hormonal levels and there is improved erectile dysfunction and semen parameters in many of these men. However, some observational studies have shown that unpredictably, bariatric surgery may lead in some men to worsening of sperm parameters or even to azoospermia in some of these men. This may be temporary or it may last for some time. And indeed, a systematic review and meta-analysis published in 2018 of the effect of bariatric surgery on semen parameters didn't show any consistent result. Some studies have shown improvement, some studies have shown no change, and others have shown worsening. Therefore, the practical advice that follows from this knowledge is that men who are contemplating bariatric surgery and they would like to father children afterwards should be advised to freeze their semen samples pre-operatively. And following the bariatric surgery, their partners can come for the treatment almost immediately. Delaying the treatment in the man doesn't make a difference, but in the woman it does make a difference, as we say, and because we have frozen semen samples preoperatively, we don't worry about the change. Therefore, ladies and gentlemen, I would like to conclude by emphasizing that in the female patient, bariatric surgery will improve the altered reproductive hormone profile, restore menstrual regularity and proper luteal phase function, but pregnancy should be delayed for at least a year to a year and a half to reduce the effect of inevitable nutritional deprivation on the increased incidence of fetal growth restriction. After that, we know that bariatric surgery will lead to an improved ART outcome, but it could be associated with a drop in the AMH following surgery, and therefore that should be checked and the dose of medication should be altered accordingly. Also, because of the skin redundancies that inevitably follows significant weight loss, there may be poor absorption of subcutaneous drugs and the intramuscular route is much preferred. Moving on to the male patient, we can also conclude that it improves the altered reproductive hormone profile and can in many men improve erectile dysfunction and semen parameters, but in some men it may be associated with some reduction in semen parameters, and therefore pre-surgery semen cryopreservation is advised. But the main benefit of bariatric surgery to our patients, whether males or females, is that it leads to significant and sustained weight reduction, and that will improve their overall health. Therefore, it should be highly recommended for our suitable patients, and we should take those particular provisos into consideration when offering them ART. Thank you very much for your attention.